Camran, it's 1 o'clock.
Hello, everybody. I am Dr. Camran Nezhat, the founder of the Worldwide Endo March. I would like to welcome all of you for another session of the Worldwide Endo March. And I would like to thank all of the participants, all of the audience around the world for their interest in this series. My thanks on behalf of myself and co-founders of the Worldwide Endomarch, Dr. Farr Nezhat, Dr. Ceana Nezhat, Dr. Azadeh Nezhat, and Barbara Page. And also, we would like to thank all the chapters of the Worldwide Endomarch around the world in more than 60 countries for their significant contribution and assistance in helping patients with endometriosis and their families, and in helping to raise the awareness about endometriosis and its implications for women and their families and the society. Also, we would like to thank enormously the participants of every session, and in this session we have two prominent speakers, Drs. George Pistofidis and Dr. Sunita, that they are both very experienced from Europe and from India to address the very important issue of the adenomyosis and also myoma of the uterus and its relation with endometriosis and its implication with endometriosis and in patients with endometriosis. All of these efforts are for patients and their families, and we are lucky to have this time another one of our patients that another one of our patients, Miss Brittney Bruschera, that she is going to share her story and her journey with endometriosis and adenomyosis and pain or issues related to her, as the story of the last month with Miss Lily Cooper was very, very popular. And because of that interest, that more than 8,000 people watched, we have included and we are going to include more stories specifically each time about the patient stories. And also the efforts of Worldwide Endomarch is continuous. There are a large group of volunteers that around the globe work and try to do the mission of the Worldwide Endomarch. And in the headquarters, these are under the direction, guidance, and efforts of Zoe Pennington, Tiffany Letosky, Eliza Ackroyd, and Andrew and Lily Cooper, that are all volunteers and continuously doing a lot of work. There are many other people that they are doing in these efforts, and I'm sorry if sometimes I forget to mention everybody. But a great and significant thank goes to all of you and all the volunteers, because the basis of these educations are volunteers. The goals are that we make sure everybody knows about endometriosis, about adenomyosis. The word of diabetes and hypertension is very easily understood everywhere, but endometriosis is not easily still recognized all around the world as easily as hypertension or diabetes. But we are making progress. We are making it easier for people, for physicians to diagnose and treat endometriosis, and hopefully someday we will find a method of prevention. As you know, Worldwide Endomarch has developed an app that it has dedicated to the society. It is completely for free, and it costs many years and significant amount of budget to produce it. It is called Nezhat Endometriosis Advisor, and easily it can be used for the diagnosis of endometriosis with high accuracy as a guideline to help the patients around the world. Areas that there is no operative laparoscopy or there are no tests, other ways to diagnose endometriosis. Now, saying all of that, I would start, and I would like to start in this session here, our session of the endometriosis and adenomyosis and fibroid with Brittney Bruschera. And Brittney, start please and go ahead and tell us the story of your journey with endometriosis.
Absolutely. I just want to say good morning, good afternoon, good evening to anybody that is watching. So I'll just go ahead and start my endo story. So endometriosis was not spoken about before my diagnosis. I had no idea what it was. I heard about it being bad periods, but I had no concept about it. Now that I've done more research, I know that it's often underreported because symptoms are things as women like to brush off every day. For example, having a painful and heavy period, a frequent UTI, lower back pain, IBS, and SIBO. In the early stages of my symptoms, a lot of the times during my meetings with doctors, they would say that the pain I was feeling was normal or just to take a pain reliever to deal with it. However, since my symptoms were interfering with me going to school, being able to sustain friendships, and not being able to go to work, I knew that was not normal. I remember being at a friend's house and having this excruciating pain on my left ovary. And the way I like to describe it was like a electric sewing needle that was on and on overdrive on my left side ovary. And I remember not being able to breathe and feeling extremely lightheaded and nauseous. The pain subsided the next day, but it happened again the next month around my next period. It was about a whole year of that same cyclical pain before I decided to go see my gynecologist about it. She told me, based on where my pain was, she didn't think it had anything to do with my period. She thought it was something to do with my digestive system and referred me over to a gastrologist and a nutritionist. And I said, okay. However, the pain started to get worse, so I decided to get another opinion. I met with another gynecologist, and she started asking me really pointed questions like, is sex really painful for you? Are you having bad pain days? So bad that they keep you from working? And I was like, of course, yeah. So she prescribed me a new birth control, but the pain started to get worse. I saw more doctors, was put on numerous medications, but nothing seemed to help. It was to the point that when I worked out, it would leave me out of breath, was having constant nausea, extreme lower back pain. It felt like this buildup of different symptoms, and I felt awful and not like myself. I started to get at a point where I felt like I was going to feel this way forever, and I knew I didn't really want that for myself. I felt so defeated and frustrated. It was many years after that I took my own health into my hands and found a doctor that would help me. I was lucky enough to find Jacqueline Della Merced. She actually gave me the best advice and referred me over to Dr. Nezhat to get my laparoscopic surgery done. Endometriosis is a disease where the tissue, similar to the lining of the uterus, grows outside the uterus, and it starts to attach to all kinds of tissue. for me, endometriosis attached to my ovaries, bowel, bladder, and back. I'm really grateful for Dr. Nezhat because he actually told me I'm not going crazy. And as an endometriosis patient, you tend to feel like you're going crazy because you don't get enough answers. And you're just left going, what is going on? And giving me my life back. My advice to those that are dealing with endometriosis is to really trust your gut and not be afraid to get those second, third, 20th opinions. I think it's really important that we start talking about these pains women are feeling in a different way. I think it's important to speak up and elevate the conversation. And that's why I'm so grateful to be here today, so I can hopefully help you get some more clarity. But yeah, that's my story.
Thank you very much, Brittany. You are very, very kind. Thank you for your comments. And that brings us to the issue of association of endometriosis and adenomyosis. And the what we are going to address is with Professor Pistofidis from Greece. He has extensive experience about managing patients with adenomyosis, and there are so many questions, and the question that we have also posted it, we have combined all these questions that Dr. Pistopoulos is going to address it one by one, and also the association of adenomyosis with endometriosis. George, please go ahead. Thank you for being in the program.
Well, thank you very much for your invitation, and hi to everyone. I think you're doing a great job. I think it's so important to address these issues and educate the women around the world about these very important problems. Well, I would like to make a very brief introduction to explain what adenomyosis is. And adenomyosis is basically the presence of endometrial glands inside the myometrium, and that's where the word lies: adenomyosis, gland and muscle. Now, how this happens, it's not totally understood. We think these are potentially metaplastic problems or genetic problems or immune problems or the combination of these problems. But the end result is that when these glands find their way inside the myometrium, they cause fibrosis. And fibrosis means thickening and hardening of the muscle. The end result of this is extensive and very powerful contractions, which we call hyperperistalsis or dysperistalsis, which means abnormal contractions, and that is what's primarily causing the pain. So talking about symptoms of adenomyosis, which is the question, I think the main symptom is pain. And pain could be in various forms. Could be cyclic, which means painful periods, which in medicine we call dysmenorrhea. It could be painful intercourse, which in medicine we'll call dyspareunia. It could be chronic pain, i.e. pain continuously, women suffering outside the menstrual cycle. It could end up with bloating, which is swelling of the abdomen, and of course, infertility. So this is a combination of symptoms that adenomyosis causes. And of course, there are different types of adenomyosis, and this we will address later on. But I would say the primary symptom, like with endometriosis, is pain again. I don't know if this answers the question.
Yes, excellent. Thank you very much, George. Now, there is one question that Dr. Ceana Nezhat would address. What is the relationship between adenomyosis and infertility, and how do we deal with it?
As mentioned, first of all, good morning, good afternoon, good evening to everybody, and thank you for the opportunity. As you heard, adenomyosis is like endometriosis, is a general definition. We have variety of the adenomyosis. Actually, Dr. Pistofidis has his own great classification. So it depends how much of the uterus is involved with adenomyosis. Is it glandular? Is it diffuse? Is it fresh or sclerotic? So in general, depends on the type of the adenomyosis. It definitely could affect the fertility. Mostly implantation could be affected. It could have heavy bleeding, poor responders, because majority of patients who have adenomyosis, they have endometriosis too, and it becomes a multifactorial who affects the fertility on different aspects.
Thank you very much, Dr. Ceana Nezhat. The next question is for Dr. Sunita. And Dr. Sunita, there are a lot of, again, questions in relationship to adenomyosis, myoma of the uterus, fibroids. And please go ahead, describe what are fibroids and what are the symptoms and how would you manage them. It is okay if you address all of them at the same question. Dr. Sunita has extensive experience in respect to infertility and myoma of the uterus, pelvic pain, endometriosis, and she has been involved significantly in teaching and managing patients. Please go ahead. It is a pleasure to have you. Please unmute your camera.
Thank you, everybody. Sienna, it's a great pleasure to join you in this journey of Endo March. Thank you for giving me this privilege to be with you all and to answer and address the society at large with various concepts and misconceptions and understanding of the subject more better. So, fibroids, these are the tumors of the uterus. How we can have adenomyoma. Similarly, there can be a tumor in the uterus. Now, these fibroids we call, or a myoma, the another synonyms, they can be within the uterus, they can be in the wall of the uterus, or they may be outside the uterus. And depending upon their size and depending upon their location, they can vary in their symptoms. Those myomas which are in the cavity of the uterus, these myomas obviously will cause you pain during menses, excessive bleeding during menses, or maybe it will cause fertility issues. Those within the wall of the uterus, and if they are big enough, they may cause a pain, chronic pelvic pain, or only pain during menses, or it may be during the relationship. While the myomas, which are outside the uterus, we all know that in front of the uterus is the bladder, urinary bladder, and behind the uterus is the colon. So if the myoma is anteriorly compressing, it's a big one on the anterior aspect of the uterus, then it will cause a bladder symptoms. If it is on the back side, it will cause pressure symptoms on the colon as simple as constipation or maybe pain while passing motions. If they are on a lateral side of the uterus, sometimes they can cause obstructions to the ureters. That may give acute pain to the patient and she may need a emergency attention. So depending upon their sizes, depending upon their locations, depending upon their number, sometimes they may be inside, they may be outside. And most importantly, everyone should know that sometimes it may cause just the lump. A lady may come saying, I'm feeling something in my lower abdomen. It's bulging. My pant is no more now fitting me. And sometimes you just find it when you go for a health checkup. So they are totally asymptomatic and you are accidentally finding them in your health checkup sonography reports. So various things they can.
Thank you very much. The next question is for Professor Pistofidis. The endometriosis and adenomyosis, how often in a patient has both of them? And are there different stages for adenomyosis? What are mainly, I mean, what, how do you make the diagnosis of adenomyosis in a patient?
Well, thank you, Cameron. I just want to say that whilst endometriosis is a well-studied disease, it's been studied extensively for many years, and there have been tens of thousands of publications. Adenomyosis is a relatively younger disease. There are fewer years that people have been studying and publishing on adenomyosis, and the main reason for this is imaging techniques. So it's progress in technology that has put adenomyosis on the map. Until the 80s, the adenomyosis diagnosis was on histology reports from hysterectomy. But after 1980, with MRI, magnetic resonance, and with the ultrasound, and with the possibility of many doctors having ultrasound in their offices, that people have started recognizing this entity. So that's why I use the word young disease. So it's a younger condition. Now, endometriosis, we know, it's a common problem. It happens to many women, and not only in women with pain, but also in women without pain. Adenomyosis is also happening in a reasonably proportion of women, and it's very commonly found, especially in women with pain, with endometriosis. The publications vary. In my series, we have about 40% of women with adenomyosis also having endometriosis. But you have to understand that this is an important ethnic difference between ethnic groups. There are variations. In some series, endometriosis and adenomyosis, especially in patients who suffer with pain, can be found in up to 70 or even 80% of women. So endometriosis and adenomyosis seem to share some common pathogenic mechanisms, like genetic mechanisms or immune problems that both end up having these two conditions at the same time in the same patient. And that's why pain, and one contributes to the other.
Very good. Well, thank you very much. We have to recognize, dear audience, that since the introduction of video laparoscopy and the revolution of modern day surgery, the technology has advanced significantly. We have excellent cameras now, excellent light sources, and high definition monitors, 3D visions. Thus, we are able to see in the abdominal and in the chest cavity, in all the body cavities, much better. We can see the anatomy and the pathology much better than we were able to see before. Thus, we are able to diagnose endometriosis that a lot of times are small little spots, and ultrasound doesn't show it, MRI doesn't show it, CT doesn't show it, but when you look, you can diagnose. For example, all the literature, all the medical publications, they were mentioning that only about 20% of patients who have fibroid have endometriosis. Until recently, we have published 2 papers and we have done significant research in this area, and we are finding more than 85% of patients who have fibroids have endometriosis, pathologically proven. So we have proved that women who have fibroids, more than 85% of them have endometriosis. That has a big implication. That means if 1 out of 5 women in the world has fibroid, more than 85% of them have endometriosis. The number of patients with endometriosis in the world is far more than 200 million. That we have been saying, and we have said that the number of the patients with endometriosis is far more than 200 million. And time would prove that that is correct. So women, patients are not imagining it. It is not in the head that there is pain. So sometimes the adenomyosis or myoma by itself might not cause pain, but that endometriosis component might cause pain, or it might contribute to infertility. Fibroid by itself might not contribute to infertility, but that endometriosis associated with it does. And also this has another implication, as patients with endometriosis could have a higher chance of cancer. And that brings me to the question that asked Dr. Farr Nezhat, what are the risks of the patient who have adenomyosis, endometriosis, and fibroids and dealing with cancer? Dr. Farr Nezhat? Okay, we will proceed with, it seems like Dr. Farr Nezhat is not there.
No, but Farr is here. He was muted. He's back. He's unmuted.
First of all, thank you very much for the invitation, and good morning, good afternoon, and good evening, people around the world. So this question has 3 components: the possibility of the malignant transformation of the endometriosis, possibility of malignant transformation of adenomyosis, and also malignant transformation of myoma. So definitely we know that endometriosis could become malignant. The most common area of the endometriosis become malignant is on the ovaries, and there are histologically different types of the cancer could arise from the endometriosis on the ovaries. Also endometriosis of other parts of the body, like a bowel, and sometimes bladder, and even other parts of the abdomen, like incision of endometriosis, all could become malignant, unfortunately. The chance of adenomyosis become malignant also exists, but the chance is less. No, we don't know the possibility. We know that the uterus could have cancer of the lining of the uterus, or endometrial cancer, and sometimes adenomyosis that has become malignant, but the chance is much less. Chance of the uterine myoma become malignant also exists, but it is less than maybe 1%, based on different reports, which is called sarcoma. So each of them, unfortunately, there is a potential to become malignant, but overall, the good news is the chance is low. It's not zero, it exists based on the areas of the disease. The chance is different, but awareness of this condition is more important than a statistic. But unfortunately, it could happen to younger patients, and most of them are perimenopausal and sometimes after menopause.
Thank you very much, Professor Farr Nezhat. The next question is for Professor Sunita, is in relationship to fibroids, when do you do surgery if the patient wants to get pregnant? When do you do surgery if the patient and what kind of surgery do you do if the patient doesn't want to get pregnant, and or when are you going to do IVF for this patient? You are muted. You are muted, Professor Sunita.
Thank you for your question. It's really a $1 million question in infertility, when to operate on a myoma and when not to operate on a myoma. Because if you operate on a myoma and if patient doesn't conceive, then you are answerable to it. So when you are in doubt, cut it out may not be right in a fertility. What is important, if the fibroids are inside the cavity, we call it as a submucous myomas, and they are large enough or they are multiple, and you don't have any other reason why patient is not fertile, it is advisable to remove all those myomas which are within the cavity. Now, the question is, if the myoma is outside the uterus, that is sub-serous myomas, these are myomas which are not needed to be removed because they are not directly coming into the contact for the implantation per se. Very, very rarely, if they are at the corneal region and if they are blocking the fallopian tubes, then maybe the reason you need to remove them. So unless the subserous myomas, those myomas which are outside, probably you don't need to remove for your fertility. The main important, always a controversial point is the fibroid which are within the wall of the uterus and they are medium size, like 4 to 5 centimeter. They always cause a dilemma for the fertility specialist. So any myomas which are those medium size, but they are compressing the cavity, they are going to alter the implantation. And those cavity distorting myomas, even if they are in the wall, not inside, they should be removed. Only those myomas which are very small myomas, they are away from the cavity, they are in the wall, they may not be removed. But if they are multiple, for example, there may be 2 centimeters, 7, 8 myomas, then altogether they may impact. So, but it's not advisable to do the surgery for such a small myomas which are located at multiple. So sometimes the fertility specialist might have to use medical line of treatment to temporarily reduce them. No medical line of treatment will permanently dissolve them. They are there just to reduce the size. So it is the fertility expert who can tell in that patient. But you had very rightly said that myoma may be associated with endometriosis. And if it is a subserous myoma, one don't know the cause why patient is not becoming fertile or pregnant, then putting a laparoscope inside to examine any other factor, you find associated endometriosis. But if I had gone inside doing laparoscopy, and if the patient has significant size of 6 to 8 centimeter, I would remove even that myoma because sooner or later she will need the surgery for that. So it's very important that you sit with the patient, you have a proper mapping of the myomas, either by the great sonologist or by MRI. Sit with and discuss the patient how you feel those myomas are affecting the fertility, and probably you will help her to restore her fertility, or probably her implantation after the IVF result will improve if we remove those myomas. I think technological advances, as you said, whether hysteroscopy or laparoscopy, making it a daycare surgery, has helped the physicians, surgeons, as well as the patients to undergo this successfully. So one more request is whenever you do it, try to do laparoscopically.
Thank you very much. So there is a question, and that is also for you, Professor Sunita, in relationship to myoma. And this patient says, I have had many failed IVF cycles, and patient has fibroids. And her physician doesn't believe the fibroids are the contributing factor. So what should she do? She has had many failed IVFs. Could she keep going having IVFs? and her physician says fibroids do not cause infertility, what would you do? What is your recommendation?
I will do first her IVF. I'll freeze out her all embryos and I will do removal of these fibroids unless I find the other reason. If the fibroid I feel are within the cavity or compressing the cavity, definitely I will suggest the fibroids are the cause why implantation failure is happening. I will remove it definitely.
Thank you. So, Professor Pistopoulos, exactly another patient, she has had many failed IVF cycles, she has diffused adenomyosis, and what would you do and what do you recommend that she should do?
Well, that's a very, very difficult question because adenomyosis can be of different types. And this is our classification, which we have presented some time ago. Adenomyosis can be, like you very correctly mentioned, diffused adenomyosis, which is affecting the whole of the uterus. Or it can be focal adenomyosis, which means more localized disease in a particular area of the uterus, which could be the anterior or the posterior aspect of the uterus. Now, we have divided the focal types of adenomyosis into three different sub categories, which is the larger lesions, which are very hard, and we call sclerotic, which means hard. Then some smaller lesions, which are nodular, and they're closer to the top of the uterus and near the ligaments, and we call those nodular adenomyosis. And then we have a very rare condition, which is cystic adenomyosis, and that is found in the younger age groups. Now, it's very important to understand these types of adenomyosis and surgery, because you have to understand that whilst you remove a fibroid, the uterus remains more or less unaffected. The uterus remains intact. But if you remove adenomyosis, you actually remove part of the uterine wall, because adenomyosis means fibrosis of the uterine wall. So the bigger the size of the lesion, the more uterus you remove, so you affect and you alter the future fertility and the capacity of this uterus to carry out a successful pregnancy. So one has to be very diligent in how to manage, how to decide which lesions are adequate, are presenting themselves for surgery, and which lesions should not be managed by surgery. Now, when it comes to diffused adenomyosis, which you mentioned, I think it's impossible to remove the whole of the adenomyosis. Some workers have attempted that, and they've given some interesting data, but it's very difficult surgery and can end up with actually destroying the uterus. So I think for diffused adenomyosis, it's better to do conservative treatments with GnRH analogs, trying to stop the menstruation for a while, and then attempt an IVF cycle again. For other types of adenomyosis, which are the focal lesions of adenomyosis, I think surgery can be efficient, especially if these lesions are less than 30% of the uterine mass, of the uterine wall. Because in those particular cases, you can remove more or less the whole lesion until you reach healthy myometrium and then suture together good myometrium, which gives a very strong uterine scar with a successful pregnancy. And our experience with women who suffer from focal lesions is that the majority of these women can be managed by laparoscopy, like you mentioned earlier, and can be managed conservatively without having to go to a full hysterectomy. Now, when it comes to IVF attempts, again, if you have focal lesions and you have multiple failures, I think one can consider to do surgery for adenomyosis, but has to be extremely specialized and experienced in this type of surgery, because you have to be very careful how much uterus you remove and how much lesion you can successfully remove, and then replace, suture the uterus again to make it a functional uterus. When it comes to diffused adenomyosis, Unfortunately, the only solution, as far as I'm concerned, is medical treatment and then carry on with future IVF attempts.
Thank you. When you remove these adenomyosis lesions, how long do you tell the patient to wait to try to carry a pregnancy, and do you ask all of them to have a cesarean section?
Well, thank you very much. It's very important when you remove adenomyosis to have an accurate diagnosis preoperatively, so that you know that this patient is eligible for good surgery. So you have to suture healthy myometrium, like I mentioned beforehand, with healthy myometrium. If you suture adenomyosis together with adenomyosis, you don't have a very strong scar, and that is a problem. So it's very important for the surgeon to be able to recognize the limits of the lesion and remove it as much as possible and find healthy tissue and suture that together. If you do that, then I think about 6 months is probably sufficient to allow this uterus to heal completely. And then, of course, we assess by sonography, make sure that the lesion has been removed. And after that, I think it's safe for the woman to go ahead with a pregnancy. Now, as far as outcome is concerned, I think I would opt for a cesarean section. Definitely, I would do a cesarean section, not at term, but probably a wee bit before term, around 37, 38 weeks.
Thank you.
George, can I ask you a question? George, thank you very much for excellent explanation. 2 questions. One, what do you think about the role of the myometrial ablation and also uterine artery embolization in women that want to get pregnant with diffuse adenomyosis?
Well, to be honest, I have not had much experience with uterine artery embolization. Neither have I got experience with myometrial ablation. My experience has been mainly surgical to actually remove the problem. I have not managed many women requesting fertility with embolization. So I wouldn't know if that would be the correct treatment for women with diffused adenomyosis to offer them uterine artery embolization. I don't know what's your experience with this condition.
Well, I am in New York, and because besides oncologists, I get this referral for these women that don't want to get pregnant, they don't want to have hysterectomy. They want to get pregnant, and like that patient that had failed several courses of IVF, and one subject has come up that maybe we should try uterine artery embolization or myometrial ablation. So me personally, like you, don't have enough experiences. But definitely I have seen patients that have been referred to me or they came to see me for consultation and this subject has come up. I don't know if Dr. Sunita Tandulwadkar or Camran or Ceana have any experience.
No, I am not have uterine artery embolization. Neither I feel it will effectively work for these infertile patients. I'll be little worried about doing uterine artery embolization. But what I do with this diffuser, I think George has answered so beautifully about the adenomyoma and the concern with the surgery in an infertile group. But in diffuse adenomyosis, what I do is I always go for the frozen embryo transfer. I freeze the embryos and around 6 cycles of GnRH agonist or amenorrhea, and then I do the frozen embryo transfer. And I see it gives me wonderful result. It's not only, we all know that it is not only the reduction in the size of adenomyosis, but it is decrease into the chemicals, the interleukins and other which natural killer cells and all those get decreased. You get a favorable immunity, and because of the shift towards the favorable immunity, we all know that adenomyosis, apart from the structural things, they also alter the implantation because of a altered local immunity. And by making a amenorrhea for 6 to 7 months, we help them to shift to the favorable immunity and hence the implantation. I will never go for the fresh transfer. I will never do the suppression first and then stimulation and a fresh transfer. Because whenever I'm stimulating, I'm causing supraphysiological level of estradiol and I'm changing the immunity quite a lot. So I will always suggest freeze-on, give amenorrhea of 6 to 7 months. If it is a very massive adenomyosis, you may go for 9 months and then do the frozen embryo transfer. Only thing is, if you are not doing obstetrics, give it to the obstetrician who knows how to manage not only the ART pregnancy, but these adenomyotic uterus. Usually, you will have oligohydramnios or a small sized babies. So one need to be very clear about managing those patient even, because ultimately carry home baby rate is what is important for all of us.
Thank you. Thank you very much. In general, there are no significant data to one way or the other, but there are anecdotal data that we should not use uterine fibroid embolization for the patients who want to have children. Mainly, it may cause intrauterine growth retardation because the blood supply to the uterus would be significantly less. Thus, I don't believe it is a good idea to do uterine fibroid embolization or uterine artery embolization in case of adenomyosis excuse me, when the patient wants to get pregnant. In case of myeliosis, again, there are no data, but we do not want to damage the uterus. If the adenomyosis is superficial, and I usually very carefully, selectively, I try to gently desiccate it as long as it is a focal area and it is not too much. Then the patient doesn't have to wait a long time. But if it is diffused adenomyosis, hormonal suppressive therapy between 6 to 9 months and sometimes longer, that is what it is advisable. And that brings me to the next question that I would like to ask Dr. Azadeh Nezhat, that how many kind of fibroids there are and what is the association between them and endometriosis, if you would like to address it. And if the patient doesn't want to have hysterectomy and she has already completed her childbearing and she has all the children she wants, but she has symptomatic myomas and she still wants to keep her uterus, how would you manage her? This is a patient who has had children, she has fibroids, and she says she doesn't want to have hysterectomy, and she is 55 years of age.
Good morning, everyone. I think Dr. Sunita and you addressed the types of fibroid as far as where they are, where they're located in the uterus, how we divide them into the cavity that are called submucosal, into the muscle, intramural, and then outside of the uterus, they're called subserosal. As far as the endometriosis, what percent, but to answer those, I think you answered the 87% of the patients with fibroid, they do. There was a study in 2016 that we published that showed more than 87% of the patients with fibroids are histologically have endometriosis also. So those two, I think you answered them. As far as how do you manage a patient that does not want to have a hysterectomy, but has multiple fibroids and is symptomatic? Um, you know, we've done myomectomies. You could debulk the fibroids by doing a laparoscopic or doing a LAM, remove the fibroids to reduce the bleeding and the pressure on the pelvic organ. Also, you can manage them by putting an IUD if they have bleeding, but if it's a 55-year-old still wants to keep her uterus, there are times that we do myomectomy.
Thank you very much, Dr. Azadeh Nezhat. Dr. Ceana Nezhat, there is a question that some patients are worried about fibroid and cancer, and what percentage of the patients with fibroid have cancer, and how should they be managed if you remove them by laparoscope or by laparotomy? How would you manage it? And then also Dr. Farr Nezhat, from an oncology point of view, after you answer it as a non-oncologist, and then Dr. Farr Nezhat would address it as an oncologist.
Well, this is a good question. But before I answer this question, I go back briefly address what Dr. Farr and Sunita and George mentioned about embolization and myolysis. I've done surgery on patients who have had embolization and myolysis, both after they have failed getting pregnant or their symptoms continue. I do agree with all of you. It is not a good idea to embolize adenomyosis specifically for two reasons. One, we don't know what we are embolizing. Second, it makes, if you have to do surgery, it makes it more difficult. When it comes to the fibroids, there are some data from the radiology standpoint who address that they could get pregnant. The one that I get is the one who didn't get pregnant. And when I want to do myomectomy on them, the necrotic or sclerotic fibroid makes the surgery more difficult. But in support of what all the panel said, in infertility patients specifically, it is better to approach it surgically. Now, to answer this question for you, statistics of a cancer and myoma, we don't know if the fibroid is getting cancerous or no. This is a sarcoma who develops by itself on the patients that mimics the function of the or similarity of the fibroid. And Dr. Farr Nezhat could answer it better than me. Regardless, at the time of the surgery, we have to think it could be cancer, even if the statistics are low and the chances is less than 4 in 1,000. Still, we take the precaution by proper tissue extraction. So it's been mentioned properly. There are 3 parts in myomectomy. First, removing the myoma from the uterus. 2, reconstructing the uterus. And 3, extracting the myoma from the abdomen. And this all has to be individualized.
Thank you very much. Dr. Farr Nezhat, would you like to address that?
Well, the issue is that this sarcoma or malignant myoma starts de novo, it starts it from the beginning, or myomas become malignant. It is a good subject, but definitely we know some benign fibroids that has been there for a while and did not cause any problem, later on become malignant. And the way that we know is that this patient has had fibroids and has been watched for years, and all of a sudden, some changes happens either in the size or characteristic of the fibroid, or the cancer patient comes with metastatic cancers. So we know that this happened, unfortunately, and because this is a very aggressive cancer, if the patient had it years before, she would have had sign of metastasis. And this could happen most of the time that the patient has fibroid before goes to menopause, and then after the menopause, all of a sudden, these fibroids that are supposed to be fibroid now get bigger, and either put pressure in the abdomen or the surrounding area, or causes other issues like bleeding, and comes to the physician. But there is a potential that some of this cancer starts de novo, and even though it's small, become malignant. Especially if you see it inside of the uterus, that sometimes the patient has a small fibroid, and when it is removed, it is cancer. The possibility is low, but we see it.
Thank you very much. Would you like any of the panel, George, Dr. Sunita, anybody has any additional point that you would like to mention? Would you like to say anything else? Do you have anything to add? Perfect. Brittney, I'm sorry.
One more thing I'd like to address. When we talk about fibroid, again, there are variety of the fibroid, and that's, we have to communicate with our pathologists. Like I have had patients who myoma, they have done myomectomy, pathology has come back atypical myoma. Myoma, I've had, they call it bizarre myoma, and then the variety of the myoma. So working with a knowledgeable pathologist to look at the tissue globally is also very important. Thank you.
Thank you very much. I would like to thank all the panel, Professor Pistofidis, Professor Sunita, and Professor Farr Nezhat, Professor Ceana Nezhat, Professor Azadeh Nezhat for their contribution. Also, I would like to thank Dr. Agrawal and Dr. Jackman for their contribution to this panel. And I would like to thank immensely the organizers from the headquarters of the Worldwide Endo March, Zoe Pennington, Eliza Ackroyd, Tiffany Letoski, and Lily Cooper, and Anuj Wade. They worked for the whole month to put a program together for you, and we thank you. We thank them very, very much, because Worldwide Endo March around the world is done by volunteers. I would like to thank Brittney Bruschera for her contribution for this session. The session of next month would be about diet, about acupuncture, about physical therapy, about herbal treatment, about fitnesses, and other alternative treatments for treatment of endometriosis, for adenomyosis, etc. We thank all of you around the world for your interest and contribution and helping patients with endometriosis and adenomyosis. And we wish you wonderful health. We continue to remind you to be careful, stay healthy, socially distant, and take care of your health. We wish all of you the best of luck, and we thank you very much again for your participation and your interest. Best of luck. Bye-bye.
Thank you.